Good morning. We're pleased to welcome you here this morning for the release of a report that provides a snapshot of the extent to which Americans currently participate in their health care. I'm Doug Camero from the Research Institute RTI International. I'm a family physician and a preventive medicine specialist, and I chair the Board of Trustees of the Center for Advancing Health, who researched and created this report, the one that we're releasing today. But I'm speaking to you today not just as a doctor and the chair of the board, but also as a caregiver for my 86-year-old mother and as a patient myself. As many of you know, CFAH is a nonpartisan, not-for-profit, Washington-based policy institute supported by foundations and individuals that works to ensure that each of us is able to find good care and make good use of it. We all recognize that the promise of healthcare reform is to increase access to health care for many people and to improve the quality of health care for everyone. But I think you wouldn't be here today if you didn't agree with us and if you were not concerned that these legislative and regulatory changes alone will not produce the necessary improvements in health for Americans and everybody in the country who gets health care. Because we think that active, knowledgeable participation in our care by all of us, whether we're sick or well, is necessary if we're to benefit from the care available to us or to the loved ones who we care for. Here are some examples of what I'm talking about. I finished medical school about 30 years ago, and since then there have been a lot of advances. But each one brings a challenge. Surgical techniques are better. But that means that people come home from the hospital quicker and sicker, and thus they have to assume a greater burden for their care. Better drugs have helped many people live long and well despite serious diseases, but that means that you have to use them correctly, and that requires careful attention, at least, and sometimes actually a restructuring of people's lives. And we've had huge gains in capacities, capabilities, knowledge, but that means that we have more specialists, we have more diagnostic tests, and more sources of care that have to be coordinated. Coordination of care should be the responsibility of the healthcare system. But I think we all find out when we're patients that if we want to be confident that our care is coordinated, we have to do it ourselves. Medical science has advanced much more quickly than have our expectations about our role in our own care. Too often, we don't realize that participation is not really a choice. It's not just a nice thing to do if we've got a little extra time and if we've got some internet connections to look up some good stuff. Simply put, patient participation is necessary if our treatments are going to be effective. And so the questions today before us are two. First of all, what is required of us as patients or caregivers? CFAH has created something called an engagement behavior framework to answer that question. Second, how are we doing at taking on these new responsibilities? To what extent are we currently engaging in our own health care? And this morning you'll hear a report that is a careful analysis of this question as well. Over the years, CFAH has worked to raise the visibility and priority of the many strategies that support people's ability to live long lives free of unnecessary suffering. Social and economic policies, community and employer-based policies, and media initiatives. Healthcare is one of these strategies. The report that CFAH is releasing today focuses on healthcare aspect of the overall challenge of self-care for three reasons. First of all, because in order to benefit from the healthcare available to them, individuals face a growing number of requirements in finding safe, decent care, and then making good use of it. Second, these increased demands on individuals to engage in their care disadvantage those who are unable to do so and thus exacerbate the disparities that we see in health outcomes. And finally, healthcare reform has sparked a multitude of new and occasionally well-funded efforts, many of which are to be patient-centered. So there's a unique opportunity now to institutionalize support for individuals' engagement in their care into the new policies, the new measures and practices that are being developed. Let me tell you about our program this morning. You'll find bios of all of our speakers in your folder. First, we'll hear from Jesse Grumman, president of CFAH, who will present the framework and the findings and recommendations of this report. Then, Dr. Judith Hibbard of the University of Oregon, the pioneer of patient engagement research, will discuss how her work illuminates these findings. And we'll then turn to our three panelists for their responses to the finding. Drs. Chris Gibbons of Johns Hopkins, Brad Hesse of the National Cancer Institute, and Shoshana Sofer of Baruch College. Each possesses deep expertise and brings unique perspectives to the challenges of people participating in their own care. Finally, we'll open it up for discussion and questions from the audience. I'm now pleased to introduce Dr. Jesse Grumman, President and founder of the Center for Advancing Health. Jesse?
Good morning. It's great to see everybody here. I feel like I'm looking at a room of people who have been committed in various ways to both understanding and improving, increasing people's ability to participate competently in their health care, and I feel so honored to be part of such a committed group. Thank you so much for coming. So in reporting the findings of this study, I would like to tell you two brief stories about how we arrived at these findings. So here's the first one. On my 20th birthday, I was diagnosed with an advanced case of Hodgkin's disease, and I spent considerable time on life support while my doctors tried to halt the galloping course of the cancer through my body. I was devastated. Just devastated. I thought, I'm just a kid. I can't die. I'm just starting out. After I was well enough to go home, I began the daily trek to the hospital for months of radiation treatment, followed by 2 years of debilitating chemotherapy. I was skinny, I was hairless, and I was non-compliant. Each time I would get my chemotherapy, my doctor would say, well, you have to take your pills this way, this way, this way, this way. And I wouldn't do that. Sometimes I'd take 6 pills, sometimes I'd take 2, I'd take them in the morning, sometimes I'd take none. I just couldn't do it. Or my doctor warned me that I had to stay home because my immune system was at low ebb and I was at grave risk for infection. I went out dancing. I look back now at my behavior in awe. Millions of dollars worth of biomedical research that was distilled into the knowledge and experience and procedures and drugs aimed at a disease that it was costing hundreds of thousands of dollars to treat. And ultimately, that depended on a weak, skinny, scared adolescent to have its effect. I had to show up, I had to cooperate. I had to take the drugs as scheduled. I had to avoid the risks. I wasn't a very good patient, and it never occurred to me at the age of 20 that my actions could really determine my future. The central role that I had to play in order to achieve the promise of the best available treatment has been brought home to me again and again through 2 additional cancer diagnoses, the treatment of a dangerous heart condition, and the ongoing management of the conditions and the risks that are the result of that many diagnoses and that much treatment. Even with all my experience and all of my expertise, I struggle to competently perform the many tasks that keep me upright and functioning. I'm constantly impressed with the tools that are now available to treat diseases that even a decade ago were death sentences. And I am so very, very grateful. But what's widely overlooked about these advances is the extent to which their success depends on our participation. We pick the doctors. We have to show up. We have to do the exercise. We have to take the pills. We have to avoid the risks, or we don't realize the benefit. It's this insight that brings me to the second story. In 2007, the Center for Advancing Health received a grant from the Atlantic Philanthropies to advise the foundation on what it would take to increase the engagement of older people in their health care. So I was chatting around with colleagues about how to approach this when Shoshana Sofer just kind of offhandedly remarked that the task facing us reminded her of the early days of the quality improvement movement. She said, "It took those of us working on quality a long time to understand that the most effective way to drive quality improvement efforts is to identify and to measure specific behaviors that in themselves constitute better quality. After all, what gets measured is what gets done." And so we set out to identify the behaviors that constitute engagement in healthcare. We defined engagement behavior as actions that individuals must take to obtain the greatest benefit from the healthcare services available to them. This means that we're concerned with the behaviors of individuals relative to their healthcare that are critical and proximal to health outcomes, rather than the actions of professionals or the policies of institutions. The aim was to identify those behaviors that lead to the greatest benefits from care, not to explore their determinants, the individual difference determinants like age and sex, the contextual determinants like source of care, rural, urban. Because different stakeholders use the term engagement in different ways, we used a number of strategies to collect the different meanings of this term and to identify the behaviors that those meanings implied. So we interviewed 200 patients and caregivers. We reviewed the advocacy literature, research topics in the published literature, and all the relevant systematic reviews. And we conducted 57 key informant interviews with leaders in healthcare, research, health policy, advocacy, who had written or talked about or taken some role with regard to patient engagement. So this is the part that's a little like church. If you go to your report and look on page 27 and 28, we'll now sing together. I'd like you to just cast your eyes over the specific behaviors in the engagement behavior framework as I kind of go through the major topics that the behaviors fit under. In order to benefit from our care, we must find safe, decent care, communicate with our health professionals, organize our health care, pay for our health care, make good treatment decisions, participate in our treatment, promote health, get preventive care, plan for the end of life, and seek health knowledge. Now, this is a long list, but no, you can stop reading it. Pay attention here now. Nobody has to do all of these things at once. However, each of us, often with the help of a loved one or a caregiver, have to do most of these things at some point if we're going to benefit from the care available to us. Note also that most of us are mostly healthy most of the time. And so we're not aware of new responsibilities that kind of sneak up on us. Some people like me just kind of discover the hard way that, you know, expectations change over time. They change between settings, among doctors. Everybody has a different set of things that you have to do in order to get care, and sometimes you just discover them as you go along, sometimes too late. Many of us need help. Many of us need help to effectively perform these behaviors. All of us need to know that we have to do them. So once CFAH developed the engagement behavior framework, we were really struck, as I'm sure you are, just reading over this list, by just how complicated it is to actually engage in one's health care, how much time it takes, how much knowledge, how many skills, and just how much motivation it takes to actually do all this stuff. And as you know, there are studies out there that show that we don't do some of these behaviors on the framework. So for example, we're notoriously uninterested in looking at comparative quality information about health plans and providers. And our exercise habits are atrocious. But is this true across the board? I mean, really, how big is this problem of our lack of participation in our health care? We decided that the best chance of getting a good overview of the extent to which American adults currently engage in our care was to use the major publicly available national surveys sponsored by the government, private organizations, and foundations, and scout out the data on the few items in each survey that ask about the engagement behaviors. So for this report, CFAH staff reviewed 31 surveys conducted in the years 2001 to 2009, and we identified questions that asked about any one of the 42 behaviors from the framework. Data for each question were pulled and were mapped onto the engagement behavior framework, producing a rough but revealing snapshot of American adults' engagement in their health care. And we found that for the vast majority of behaviors for which data were available, about 1/3 of respondents said that they regularly performed it, 1/3 said that they tentatively or sporadically performed it, and 1/3 didn't do it at all. We organized the major findings around related activities that people are more or less likely to do, and you can see that in the 3-page summary and also in the snapshot report itself. Here are just some examples. We're more likely to have a regular doctor, but less likely to ask questions of that doctor. We don't take the actions required from our end to coordinate our care, like get copies of test results and schlep them around from doctor to doctor, but we're beginning to check whether insurance covers a specific test or a service. We tend to be less interested in following treatment plans for illnesses that don't pose an immediate threat, like high cholesterol or allergies, but we are more likely to follow treatment plans for things that are more threatening, cancer and diabetes. So 3 patterns, kind of rough patterns, emerged from what we found, and they are this. More people appear to perform simpler tasks, like make a list of medications, than complex ones, like engaged in educated, informed treatment decision-making. The depth of our participation in any one of those topic groups, and any one of those behavior sets, tends to be shallow. For example, more of us are willing to seek information about a provider or a health plan than to use that information in making a decision. And we appear to prefer to defer information and advice seeking until we have a specific need. We tend to be reactive, not proactive. Now, commonly reported barriers to participation include poor health, insufficient knowledge, skills, confidence, external support, literacy, income, ethnicity, and insurance. And it's important to recognize that while these barriers affect a sizable number of people, the lack of participation is also very common among those of us who face none of them. Now, I'm kind of skimming over the findings here in the interest of time. However, I want to note that the work performed through this study has been formatted to offer you a rich range of tools to support the work of advocacy, of journalism, survey and health services research, planners, government funders. You have in your folder the 3-page summary, and in your hot little hands, the snapshot report itself. Early next week, we'll release the complete report on the CFAH website, and that summarizes all of the data that we collected from the 31 surveys. Each one of the chapters of that report, for example, the one on organizing care, which describes patient and caregiver responsibilities for care coordination, provides a really solid picture of what's currently known about what we do to participate in our care on that topic. The snapshot section of our website will also include a compilation of 17 tables that offer additional data on engagement relative to the framework, and a searchable tool for those of you who are interested in the survey questions that will allow you to locate all the publicly available questions relevant to each of the behaviors. So at this point, you might say to me, well, you know, people's ability to do this stuff really depends on the characteristics of the setting and the provider. And I would say, indeed. The more healthcare professionals and institutions support and facilitate our doing these things, the more likely we will be to perform them. CFAH developed a set of recommendations based on these findings that serve 3 aims that we think will lead to broad increases in our willingness to participate in our care. Those aims are more effective actions by us, more effective tools for us, and care that's more accountable to and with us. Our recommendations are specifically that providers, plans, practices at the hospitals have to communicate clearly with us about what we must do in order to benefit from our care. NIH, AHRQ, and CDC should support the development and testing of new strategies to guide and support our participation. Developers of tools should build tools that we can easily use to help us solve problems that we think are important and that we struggle with to struggle to solve when problems that we think are important that we struggle to solve when we're faced with finding and using care. And finally, providers, clinics, hospitals, and employers should use health information technologies to provide just-in-time information and guidance to meet needs that emerge over the course of an illness. And for care that's more accountable to and for us, quality review organizations should incorporate measures of our engagement behaviors into quality measures and accreditation standards. And finally, NIH, CDC, and AHRQ should monitor engagement behaviors among adults by including measures linked to specific engagement behaviors in national surveys oversampling for high-risk groups. This study gives a rough snapshot of engagement, but a clearer portrait could provide focus for stakeholder efforts to be accountable for supporting efforts to their contributors, members, or patients to care for ourselves and our loved ones, could track progress in the population's engagement in healthcare, and could enable strategic tailoring and targeting of efforts to support the capacity of each of us to engage in our health and healthcare. So I want you to consider for just a moment how much is known about the delivery of healthcare in this country. The multiple national surveys fielded by the government and foundations and industry every year. Now contrast this with what's known about what we do to find and use care available to us. This study sheds light not only on how actively we engage in our care, but also on the historical bias that values us primarily as reporters on the services we receive rather than critical players in the success or failure of healthcare to improve the health of individuals or the public. That bias is outdated. We have to bring to the challenge of increasing our engagement in our care the same energy and commitment that have been devoted to increasing the access to care and the quality of care. The health of each of us, mine, yours, my mom's, your kids, our neighbors, and the health of the nation depend on our abilities and our active, knowledgeable, willing participation in our care. It's time for public policy makers, healthcare providers, researchers, government agencies, foundations, and the private sector to join with us to ensure that all of us have the support that we need to fully benefit from the health care available to us. Thank you. It gives me great pleasure to now turn to Judy Hibbard from the University of Oregon. You know, Judy's pioneering work on patient engagement provided a rich context within which to develop the engagement behavior framework and to conduct this analysis. Her advice to us along the way has been absolutely invaluable. Judy?
Good morning. I'm going to do that. Okay. But I can see you over the podium, so that's a good start. And thank you, Jesse, and thank you for this work. It's so important, and it provides such a critical resource for all of us. Jesse and I kind of started with some of the same questions, and we took a little bit different paths in getting there, but it's very interesting that our findings are so consistent. So I'm going to share with you now the path that we took. Started with the question, if we want people to be more involved, wouldn't it be helpful to really know about their ability to function in the roles that we're asking of them? And being kind of the pointy-headed researcher that I am, I thought, if we could measure this, we would really be able to advance this. Because as Jesse said, what gets measured is what matters, and it's what we pay attention to. I certainly noticed, and I'm sure you all notice, that we know people all around us who are very proactive about their health. They're on top of things. They want to be in control. They're goal-oriented. And then we know people who are just the opposite. And isn't that interesting? And what's behind that? And if we could measure it, wouldn't that be helpful? So we started out with this idea that if we could measure it, then we could know who needs more support. We could actually be more targeted in the kind of support and information that we provided people if we knew where they were with regards to their readiness and ability to take charge. I'm going to skip over the part where that long, painful part where we developed the measure, and just tell you that we were successful in being able to measure this idea. We called it activation. It's the same concept of engagement. The definition that we came up with is that for people to be activated or engaged, they need to believe, first of all, that they have a role to play in managing self-management, in collaborating with their providers, and in taking preventive action. But they also need to have some knowledge and skill to do those things. And so that's what our measure, the patient activation measure, assesses. It's a 13-item questionnaire, and people There are people who score anywhere from 0 to 100 on that measure. Once we had measurement, then we were in a very unique position to really gain some very important insights. One of the early insights was just how much variation there is out there. But we also saw that activation appears to be developmental. That is, people go through phases on their way to becoming more engaged. And we also learned that it is changeable, that people can become more engaged. We took the opportunity to start to look at people in more depth who measure out at different points on this continuum. And we got some very important insights. When we did in-depth interviews and looked at our quantitative work, what we saw was that people who are low in activation, they tend to have poor problem-solving skills. They've had a lot of experience with failure. They've tried, and it didn't work out. And they're more likely to say things like, it really doesn't matter what I do. I can't have a positive impact on my health. Or I'd really rather not think about my health. They may not understand that they have a role to play. So the number one emotion that people at the low end of activation have is feeling overwhelmed. And their experience with failure makes them more passive. Now think for a minute about someone who has a chronic illness or multiple chronic illnesses. They come in to see their doctor, and they're told that they need to do lots of things different. They need to change how they eat and how active they are and how they manage their medications. And imagine what happens. They might really try to do all that big, long list of things that they're supposed to do. But when they can't, what they most often do, and it's the human thing to do, is they do nothing. And then they feel more like a failure. So not understanding where a person is can actually create more harm. We've looked at people further up the scale here, and you kind of see the mirror opposite at the high end of activation. People are more goal-oriented. They're more focused on their health. They have good problem-solving skills and good coping skills. We also know that people at the high end don't do everything that they're supposed to be doing, but they do have kind of the skill and the knowledge, and they're doing most of what they need to be doing. We've had multiple studies, international studies, studies that others have conducted and that we've conducted. And what we see over and over again is that the activation score actually does predict preventive behaviors, such as getting screenings or immunizations, healthy behaviors like diet and exercise, disease-specific self-management behaviors, such as adherence or monitoring, as well as information seeking. But we learned something else that was very useful along the way. What this is people at the 4 levels of activation and what percentage do each of these behaviors. And we developed many of these what I call behavior maps for different behavioral domains. This one's hypertension. What we saw was for every behavior, you see this kind of stair-stepped picture, with the most activated doing more of the behavior and the least activated doing less. But as behaviors become more difficult and are more complex or require more sustained action or being more assertive, fewer people in all the levels of activation do them. They're harder. So I'm only going to show you one of these behavior maps, but we have many of them, and they look pretty much the same. That those who are more activated are more likely to engage in the behavior. But the lessons that we took away from that is that we can actually see what are realistic steps for people who are at these different levels of activation. Many of the behaviors that we're asking people to do right now as part of being a good consumer or good patient are actually behaviors that only the most activated do. Use quality information in selecting a provider. Be persistent in asking a question if you don't understand. Guess what? Only the most activated do those, and not all of them. And so one of the insights we got here is, well, maybe by just encouraging these more complex, assertive, and difficult behaviors, we're actually discouraging the least activated. Maybe we should start with behaviors that are more feasible, especially for the low activated, so that they have an opportunity to experience success. One of the key things that we saw in the low activated is that they lack confidence. It's not about necessarily that they don't have the information, because that's usually the prescription. Give them more information. If you feel like you can't do this, or you're not even sure it's your job to do it, information isn't going to help you. Building a sense of confidence and competence is what's going to help you. So one way to do that, and why people do get confidence, is by experiencing success. Then people's motivation tends to kick in when they start to see that they actually can do this. So thinking about how difficult the behaviors are that we're asking people to do is important, so that they do have this opportunity to experience success. Okay, so I told you it's related to behavior, but what about outcomes? Is this concept of activation or engagement, does it predict outcomes? This was a study that was done by Kaiser, the Care Management Institute at Oakland, where they measured activation in chronic disease patients. And then 2 years later, excuse me, they looked 2 years into the future. So this survey was done in 2004, and then they looked back, and they said, did that score in 2004, did it predict what happened in 2006 for diabetic patients? And what they found was that the activation score actually did predict whether people were adherent to their diabetic testing, whether they were in good glycemic control or not, and whether or not they had a hospitalization. So what that said to me was, this construct is robust, it does predict the future, and it is stable if nothing else happens in the interim. And then AARP did a very interesting study where they used the patient activation measure, and they looked at people who were pretty sick and had had a recent hospitalization. These were people with multiple chronic illnesses. And what they found, they just dichotomized the measures, so high activated, low activated. What they saw was that people who were low activated were more than twice as likely to have a readmission after they left the hospital within 30 days. They were more likely to experience a medical error. They were more likely to have a poor coordination between their caregivers and to suffer a consequence as a result of this poor coordination. And then, not surprisingly, if any of these things happened to you, they lost confidence in the system. So there are many opportunities by understanding where a patient is to do a better job. And now some of the demonstration sites for CMS that are looking at reducing readmissions are now using the patient activation measure to try and reduce readmissions in this population. Okay, so I said this is something that's changeable. What do we know about what actually changes activation? And we've looked at some different types of strategies. The Stanford Chronic Disease Self-Management Program is effective at increasing activation, although one of the issues is that mostly it's the higher activated who decide to go into the program in the first place, which so it means we're not necessarily touching the lower end of the dimension. We know that worksite programs that really make use of peer support and supervisor support and changing the environment also increase activation. So between the two of them, it looks like peer support and learning how to do problem solving is important support for increasing activation. I'm going to talk about tailored coaching here in a minute, and we also have seen quite a bit of evidence that appropriate clinician support increases activation. This is cross-sectional data, so it doesn't tell us about causation, but we've seen this over and over again in different studies, that people who say that their doctor helped them set goals to improve their diet, to help them set up an exercise program, or taught them how to monitor their condition, that they are higher activated. So it seems that what clinicians do can make a difference, especially in being very strategic in how they help them to learn basic skills to manage. So another way that maybe we can help people, given what we learned, we thought, what if we support people based on where they are on this activation scale? So people who are low activated, we start them out with really small steps. We give them permission not to do their big, long list so they don't feel so overwhelmed. And we sort of encourage these small steps so they can experience success. And then for the people at the high end, we work with them on maintaining the successes they've already had and to build on that and help them with relapse prevention. So really tailor much more our support. So we did a study in the disease management program where we had the coaches tailor their support, and we had a control group that got usual coaching. We looked at claims data, clinical indicators, and activation levels, and it was just for a 6-month period. And what we saw was that the group that was tailored in their support increased in activation. They saw significant increases in activation. The usual coaching did not. They also had significant improvements in blood pressure, LDL, as compared to the usual coaching group. The intervention and control group both had improvements in A1C, and there wasn't a difference there. But what we did see was that the tailored coaching group had a significant improvement or decline in hospitalization and ER use. So this, the snapshot of people's engagement really shows us the challenge that we have ahead of us, that we do have high expectations of consumers, and not all of them are ready for these high expectations. We know that engagement, the research that we have on engagement, shows how important this concept is to behaviors and to outcomes. We know that there are strategies that can increase engagement. So it's all possible. I think our challenge is how to do this on a large scale and how to integrate it into the delivery system so we can do a better job. I think this is something that we can do, and if we want to fully utilize the last untapped resource in healthcare, the patient, then it's something we must do. Thank you.
Thank you very much. So now we've heard from Jesse about the scope of this problem, and from Judy about how to measure it and the fact that we can make a difference. We want to turn now to our three researchers who will serve as brief discussants to talk about these issues in the context of their own work. They'll do it from their seats here. First, we have Dr. Chris Gibbons from Johns Hopkins, then Dr. Brad Hesse of the National Cancer Institute, and finally, Dr. Shoshana Sofer of Baruch College.
Thank you. As you've seen today, it's increasingly recognized that patients, but also providers, at times struggle. They struggle to stay on top of all the health information that's available and increasingly available about themselves or about their patients. They also struggle to make the best decisions possible. And from my perspective in the work that we do at Johns Hopkins, we're very interested and focused. We just believe that there must be a way to help not only providers, but also patients engage in their health and make better health care. And with the push and the movement in health reform and healthcare transformation, this provides some opportunities, we believe. And as we've been looking, and perhaps as you've been looking, we see that a lot is actually being done, particularly to enable, facilitate, and enhance provider decision support. The introduction of HIT, electronic medical records, all kinds of things are being done there. The question we had, though, is what's happening within this context in the healthcare system more broadly to improve patient decision support? And the answer is actually there is a little. Oh, there is a little, but not nearly enough, at least from our perspective. Historically, as we've been looking at the healthcare system, has done all decision support that was available to doctors or to patients. In the past, medical knowledge was contained in books that were written above the level of most people or in providers. So you had to go to these providers or the system in one form or another to get the information you might be seeking in order to make decisions. Well, that is changing. That is definitely changing. And today, people, patients, and physicians go to many resources to get support and information that they need to make decisions. And in fact, the most recent research is suggesting that we've reached somewhat of a milestone in this country, just released a few weeks ago from a research group in New York, suggesting that for the first time in history, more patients are turning to electronic resources for health information and support than they are to healthcare providers, for the first time in history. But that story is not just about online resources and technology. It's also about what patients need and what they're not getting currently from the healthcare system, which is why they're turning to these resources in such large numbers. The last numbers I looked at, over 160 million patients have used online resources in the internet and Google as such to search for health information and support for themselves or the ones they're giving care for. So whenever I talk about these things, the first question, because my interest is in the underserved populations primarily and minority populations, the digital divide. Well, the digital divide is real, but it is changing. It is far less about who has access and who doesn't, because even among the poorest of the poor, there is increasing and significant levels of access. But what we are finding now is the way in which people use whatever technologies they're using does differ by age, the seniors versus younger people, by socioeconomics, by race. And if we don't understand these things, the tools that we may be producing, as Doug alluded to earlier, may benefit one population more than another and therefore increase the disparities, even as we're trying to reduce them by building and developing these tools. Increasingly, these tools specifically for consumers are being developed, these electronic or e-tools. There's an emerging field of consumer health informatics, which differs from medical informatics, which are tools primarily for providers. And this is an emerging field. It's promising. We just completed the first major report on behalf of the Agency for Healthcare Research and Quality looking at the potential efficacy of these tools, and there is early evidence that suggests this is a very promising area that needs more research. But there are many barriers, as has been alluded to, and I won't go into those, but there are many barriers for patients using these tools. But in the final analysis, patients need these resources, whether they're electronic or not, and it is our hope that from this report, it will help to shift the healthcare quality reform movement and debate movement from primarily being about providers, pills, and prescriptions to one about providing high quality, sustained engagement for all patients in their health and health care. Thank you.
What I wanted to do is share a story with you. This is a letter to the editor at the New York Times to an article that was published in 2005. And in this article, the original article, there was a discussion of a patient who had gone through a number of years of chemotherapy and had with her just an inundated amount of information. Was just overwhelmed with this information. Here's a response to that. As a stage 4 breast cancer patient for the last 6.5 years, I've had to make some decisions with my doctors and by myself that have not only been overwhelming but terrifying. Meg Gaines, this is the woman in the original article, an ovarian cancer patient, is quoted as shouting, "I'm not a doctor." That sounds familiar, especially when I have had to make some one or more medical decisions. Yes, the information seems too daunting. Yes, it is because of the information available that I've made decisions that have prolonged my life and its quality for longer than the original prognosis. Unfortunately, the family doctor who knew his or her patients and was trusted, reliable voice of experience is a thing of the past. Patients must be their own advocates by being informed or having family members or friends who are informed so that they can navigate the exhausting path they must walk in dealing with their illnesses. At the National Cancer Institute, part of what we have to do is we have responsibility for getting information about evidence-based treatments, evidence-based prevention, early detection strategies out to the public. But in the past, it hasn't been to the public. It's been through the medical establishment. We're seeing something different now. We're seeing the kind of engagement that Chris was discussing and that Jesse and Judy were alluding to, whether we were prepared for it or not. Before coming down here, I picked up a journal. This is called the Interactions Journal. And the whole thing is on reframing health to embrace the design of our own well-being. Now, this is the journal that people out in Silicon Valley read. It's all about creating these electronic tools that we're talking about. I don't know if you've been noticing, but Microsoft, Google, Intuit, a number of these very large commercial firms have noticed that people are engaging, whether we were prepared for it or not, in their health. And I don't think our medical systems are ready for it. That's what we're trying to invest in now at the National Cancer Institute. We need to be able to align our forces for quality where patients are at the first line of that force for quality. And that's what we're looking at. I also listened to someone from the National Health Service in England. They were confronting a very large economic deficit in their National Health Service. Sound familiar for conversations we've been having here? And they said that the only way we're going to be able to move this around and create better quality is to engage patients and to give them the tools that they need so they can monitor their own care over time. And by doing that, they'll live longer, they'll be more engaged in preventive medicine, they'll be more engaged in checking their status routinely and frequently, and they'll be more compliant. And they said if they don't do that, they're going to bankrupt themselves in the next 10 or 20 years. Right now, there is a lot of discussion about healthcare reform. There's a lot of discussion about how health information technology and an infrastructure for health information technology can help us make a new environment for health in this country. It's a time when we need data to bring to bear to inform that discussion. At least that's my perspective at the National Cancer Institute. Now, one of the surveys that we direct is the Health Information National Trends Survey. And that's one that I know that Jesse, you used in the report, and Judy, you've looked at. And we are going back into the field within a year, and we've been tasked by the Department of Health and Human Services to monitor patient engagement as one of the meaningful use goals of health information technology. I think what we'd like to do is work with you to be sure that this framework is represented in that survey. And by so doing, perhaps what gets measured will in fact help create massive change. Thank you.
Good morning. I'm going to talk about three things: history, money, and fear. So let's start with history. I had a colleague at UCLA who was a feminist historian who did these amazing analyses of diaries and letters written by women who were pioneers in the United States in the 19th century. And what she found, this is a woman who studies caregivers, is that a primary role of these women was providing nursing and medical care to themselves, to their families, and very importantly, to their neighbors. That there were no doctors there. There were no medications aside from, basically herbally based medications that was part of the lore that was transmitted from generation to generation. And in that period of time, talking about patient engagement or caregiver engagement would have been silly, because in reality, that was the predominant mode of people taking care of their health problems, for better or for worse. We have since then, of course, as several of the panelists have alluded to, seen huge gains in our biomedical understanding, in the set of tools that we have. And as that began, I want to hearken back to the work of sociologist Talcott Parsons, who defined something called the sick role, which was the specification that in return for not having to perform one's social responsibilities, that somebody who took the sick role was required, essentially, to listen and do what the doctor told them and be compliant. We are in a transition from a healthcare delivery, I can't use the word system, it's not a system, a healthcare delivery thing that is still driven by that sense of the sick role, and transitioning to this new approach of patients being much more massively engaged. We did not develop what René Dubos called decisive technologies in many cases. We didn't replace the iron lung with the Salk vaccine too many times, so that chronic illness is what we're dealing with, and for that we need patient involvement. So we are midstream here. And what is most interesting to me is the difference between the reality and the perception on everybody's part, on the part of the patients, on the part of the physicians, on the part of the hospitals. We haven't recognized that we have made this watershed change in terms of what is needed. And so for that reason, what is needed is not what is happening. So this leads me to talk about money. So here we are spending $2.3 trillion a year. It's really hard for me to get my brain around that on healthcare, okay, on health and healthcare. And so I'm putting myself in the position of a patient, and I'm saying to myself, if we're paying physicians in hospitals what we're paying them, and we're spending all of this money, why do I have to do all this work? Why do I have to do all this work? Why isn't this being done for me? Isn't that what I signed up for? I would be the sick role, and you guys would take care of me, right? And that's not working. And I think that there is a fundamental problem there, because one of the things that justifies all the money that we provide to the healthcare system is that they are doing all of this incredible stuff for us, but they're still needing more. In other words, if we were to actually add in the contribution made by people and their families to healthcare, that $2 trillion would be even higher. And I think there is some resistance to the idea of actually, kicking in, sharing the responsibility. Most doctors have a little problem with patient engagement, and that is that they confuse it with compliance. Being adherent is part of the engagement behavior framework, but so is not taking a fuzzy, confusing answer to your question. So it isn't just a matter of patients being compliant, it's also a matter of patients being a little feisty. And the only time that I often hear physicians recognize the role that patients have is when they complain about the fact that, no, I can't get these diabetes outcomes down to where you want them to be because my patients are not doing what I tell them to do, and I'm not in control of that, so I shouldn't be measured on that basis. So that seems to me profoundly ironic. So now I want to turn to the third issue, which is fear and vulnerability. And Judy has talked about it, and Jesse's talked about it, and that is that when we're sick or when our loved ones are sick, we're really scared, we're really vulnerable, and we're really afraid of making mistakes on these high-stakes kinds of actions and decisions. And for some people, it's so frightening that they just don't want to do it. In all the work that I've done with interviewing and doing focus groups with patients, there is living hand in hand a desire to have more control over the process and a yearning to be taken care of. It's a kind of an ambulatory schizophrenia, but it's very real. And I think that people also yearn to trust that everything is going to be okay, and it's not always going to be okay all of the time. So this is painful stuff. So I just want to end by saying that ultimately, engagement really requires courage. My favorite French phrase is courage, mon vieux, which means courage, my old friend. And that is what we're saying to patients. We're asking them to have courage. We are, as Judy has said, self-efficacy, self-confidence, feeling like you're not going to fail. Those are all important elements of it. Now, as Jesse said at the beginning, I'm the one who said, Jesse, make this behavioral. Don't get into these fuzzy things like attitudes and courage. But I think we all have to, from a human perspective, recognize that that's what we're asking people to do, is we're asking them to be braver. And what that means is that we have a real responsibility to provide them with the supports that they need in the way that they need them at the time that they need them. Thank you.
Thank you very much, all three of our panelists, giving us some provocative thoughts. We're now going to turn to the audience, and I know some of the people in the audience. It's a very distinguished crowd based on the people that I know. I will turn to the audience in general for questions. There are mics that are going to be around. You need to speak into the microphone because we're recording this, but I want to first ask Dr. Carolyn Clancy, who's in the audience today, who's the head of the Agency for Healthcare Research and Quality. She doesn't know that I'm going to ask her to do this. Drawing on old friendship, the agency is obviously a key player in all of this, has funded and will be funding research in this area, and is a key agency for healthcare research as well as quality improvement in this country. And so I wondered if Carolyn, who's been here for this session, would want to make a couple of remarks before we turn to the rest of the audience.
Thank you. Good morning, everyone. And I would agree this is a distinguished crowd. My biggest and best remark would just be to say bravo. I think this is incredibly important. And I hope all of us can focus on what it's going to take to actually go to the next level, because like translation, like implementation, all of this is stuff that we nod at while we're secretly thinking that around the corner is a discovery which will make this all unnecessary. So I just want us to be aware that this is going to be an ongoing challenge. You can be assured of our continued commitment to this. The other comment I would make is more as a doc. You're right, docs don't like engagement. They are way, way too busy and so on and so forth. And I also think that our healthcare system totally neglects the skill development. We think, as Judy said, that the prescription is knowledge. And I often say that as someone from a very large family, I'm the only person in health and medicine, so I get regular reports from the front about what's not working. And a whole lot of it is really, really simple information. I'm convinced that's what visiting nurses do today, is actually to translate for people in their houses what needs to happen. And we've got to get better and smarter a whole lot faster. So thanks to all of you. I was taking notes in terms of succinct quotes and so forth, and I needed an inspiration this week, so thanks for that as well.
Okay, again, if you just raise your hand, people with microphones will come to you. If you could identify yourself and where you're from, please.
Yes, I'm Barry Brouth, Health Payment Alternatives. It's a small, I'm the only consultant in it. I'm not a doctor. I used to be a state employee for many years. And whenever I would go to the doctor, I would have to call and call and call, because on the phone, I didn't get to hit button 2 for a provider, but it was button 1 for a patient. I'd finally get an appointment, maybe a week ahead, 2 weeks ahead. Then I'd sit in the waiting room for half an hour. Then I'd get called into the little cubicle, and I'd wait there for another 45 minutes. When the doctor finally came, it was as though he or she was doing me a favor. So you talk about a relationship where you're empowered. The healthcare system makes the patients feel, maybe this is just me, I don't know if anybody else feels this way, but I always felt the doctor would call me Barry and I would call him Dr. Jones. I always felt as though they were doing me a favor. And until that is overcome, we won't have the type of healthcare system that's able to meet our needs.
You're right, Barry, it's just you. Thank you. No, that's a good comment. In the back.
Good morning. Am I on?
If you have a question, incidentally, let us know to whom it's addressed.
Good morning. I'm Joanna Kaufman from the Institute for Patient and Family-Centered Care. I guess I'm wondering if there's any research that looks at if patients have families actively engaged with them in their healthcare journey, if that makes a difference.
Panel?
I think there is some evidence, specifically in the nursing home context, that patients whose families visit regularly get better quality of care. And in fact, in some focus groups that I've done with family members of people who are in nursing homes, this was in the context of talking about CAP surveys for nursing homes, and they said, you should actually ask family, we were saying, should we have a survey of family members? And everybody said yes, if they are there frequently. Because what those folks noticed is that their relatives were getting better care than the other people in the nursing home, and that they, as family members of somebody else, were often able to report on problems in care that were experienced by other people. So that's one setting where I think it proves to be very key, and I think that's because of the home part of nursing home, where I think that somebody who is a family member feels more entitled to comment on the quality of this place as a home for their loved one.
There's also another side to that that suggests it's not quite as simple as you might imply. If more people in the family are involved, we're going to get better outcomes. What we know is, for an example, when somebody gets ill, typically in white or European families, they tend to seek out the experts first. They go to the people with the MDs, the RNs, whatever degree to get help. Well, actually, that's not quite the same in minority, in African American, Hispanic, to some extent Asian population. They're much, much more family and community oriented, which is hard for some other groups to understand. But when something happens, unless you're absolutely close to death or broken an arm, they may ask the person in the family or in the community first what to do. And depending on the situation, may do that first. And depending on what they say, may be helped first. But it's much more complex. So we know from a sort of decision-making support, it's not just about information. It's far more than information is key and it's important and many people don't have it. But being engaged is about understanding how people make decisions just as much as understanding that they are or they are not making those decisions.
Jesse.
Yeah, I think that's a great question to raise for those reasons, but also because I think it highlights, from the perspective of this report and the engagement behavior framework, everybody has to do these behaviors when you're sick. And if you don't have anybody to help you do them, if you're by yourself, what does that mean about the safety and the quality of care that you receive if you're unable to do those things because you're alone? What can we set up? What systems can we set up or need to be set up to ensure that those of us who live our lives without a network of people around us are able to get reasonable care? To me, that's one of the things that the engagement behavior framework says. Here's where we need help. We are going to need help with all of these things. We need to know that we have to do them. And then some of us, because we're already ill, because we're alone, because we have a dementia problem, we're just not going to be able to do these things. What are we going to do for those people so that their care, the way that they find and use care is not disadvantaged by their aloneness?
Judy.
So at the same time, caregivers also vary in their ability to do this job. And AARP did a study where they adapted our patient activation measure for caregivers. And that was one of the first findings, is that not everyone who is doing this job as a caregiver really has the confidence and the skill and the knowledge that they need to do it. So that suggests that really understanding where the caregiver is at, we can actually provide better support so that they can do their job more effectively.
Brad.
So one final comment on that. So there has been, of course, a lot of documentation of social support. Shelley Taylor is someone who pushed a lot of that back 10, 15 years ago. But more recently, what's been fascinating is to watch the role of something like Caring Bridge and the Facebook generation. And the way that all of a sudden now, the way we design these new technologies are allowing social support to emerge in places we've never seen it before. So I think we're seeing just the beginning of something there.
I think that brings up another theme, which is that all of the health technology that's going on, some of it is not explicitly health technology. It's the social networks. And all that is being adapted to these kinds of purposes, which is really interesting. Who's next? Right here.
Hi, I'm Leah Binder. I'm from the Leapfrog Group. We represent large employer purchasers of care advancing health improvement, particularly in hospitals. And I had a question for any of the panelists. There's some evidence that we really need to improve the procedures for obtaining patient consent within hospitals and engaging patients more around that, and that can actually show great improvement in the quality of care the patients receive, as well as the improvement in the utilization patterns within the hospital. So I wondered if any of you could comment on what you think needs to happen in terms of improving the way we obtain consent.
Jesse, it's up to you.
Yes, I think it's, I agree that the consent, the world of consent is a really difficult one for us under all circumstances. The last time I had surgery, I was asked both for my consent for the surgery and for my advance directive at 5:30 in the morning after I already had a line in my arm and was waiting for surgery. So yes, I would be one that's on that team. But I do think that it needs a really systematic attention to both literacy levels and just to the whole notion. So many of us don't even know what consent is. We don't get that notion. And those of us who traffic in healthcare think, well, we just have to like dumb it down a little. It'll be fine. And we don't even understand this idea that we need to give permission, and then in some way we don't get that. So I think if you ask me more than two questions, you'll know that my answer is always, most of us don't know what you're talking about. And if you could explain that better to us, we might be able to. But, I think most of us don't have lots of contact with healthcare. And so we don't know how to do this. And we don't even know, the concept is not even available to us. So I think it's not only working on the literacy, it's really understanding that people need to be, the whole idea of what is permission? Why should I give it? What does that mean? What am I letting go of? What am I getting? Is a big deal that we don't get.
Can I just comment too, Jessie?
Yeah.
To me, the process by which we get what we call consent is really a metaphor for everything that's wrong in the communication between patients and providers. Because at its best, a good consent process involves a technique called the teach back, where you actually ask people to say back to you in their own language what they have heard, so that you are then honor bound to see whether or not they've actually understood this. And there is just a basic assumption that you don't have to worry, patients will understand. And it's so profoundly wrong that I just don't understand how a group of scientifically trained people could be so far from reality in terms of recognizing that they're talking to people in a way that they don't understand. And it really makes me question whether or not there is a fundamental commitment to the idea that it is the patient's prerogative to say no.
My name is Lowell Simpson-Taffer. I'm a preventive and family medicine physician, work for the Air Force, obviously. Question is mainly directed toward Dr. Hibbard, but to the group as a whole as well. It appeared to me that patient activation, a determinant of patient activation would be continuity of care and establishing a good relationship with your primary care provider. If that is true, how do you see the looming primary care shortage in this country impacting that?
Yeah, great question. We do have research. The Emory group looked at this question of the relationship and the trust between the patient and their primary care provider. And it is related to activation, that where there's higher trust and a good relationship, there's higher activation, there's better outcomes and improved behaviors. So the issue of what will happen under health care reform, where there's much more stress on the system, and expanding the team approach, the using additional nurse practitioners, physician assistants may be part of the answer, because what we see is that those personnel also, that a good relationship with them is also related to activation.
Chris?
So let me push back just a little bit on that. And I may get run out of Dodge for what I'm about to say. I grew up as a doc, so I know that side of the coin. But let me just say this. In this country right now, I believe the sort of basic tenets that, a relationship is better for outcomes. So don't get me wrong. In this country right now, we have about 700,000 physicians. We have about 1.5 million nurses, and we have about 5,200 hospitals and clinics. Of those 700,000 physicians, about 300,000 of them are primary care. The rest are specialists. We have 356 million people in this country. It's just not, it's not logical that every one of those is going to have a relationship with a primary care doctor in the same way we've been doing this historically. It's not possible, and it's not even the way society functions now. We don't all go to the same corner store to get our groceries anymore. We don't buy our cars from the same dealer anymore. Philosophically, it's not the way our country works anymore. And I think that's actually a stumbling point in the way we're thinking about reforming healthcare. We have to think about building relationships with every one of those people, but some will do it that way. But we've got to also think of innovative and new and different ways of providing that that meet patients' needs, not just the healthcare systems or providers' needs. And that's why, in my view, technology is very promising, because you can touch every person with the relationship, and to some extent the social networking pieces, they are providing social networking interaction which may, we don't know yet, which may be adequate to provide the level of outcomes that we're seeking in a personal relationship. We need at least to explore it. But this idea that 356 million patients are going to have a personal relationship with a doctor, in my perspective, is not even realistic.
Brad.
So I'm going to be on the same horse with you out of Dodge. Okay. Sorry about that. Yeah, here we go. You know, we get compared often to the airline industry, so from Air Force you would appreciate this. And we ask ourselves the question, when I go onto a plane, do I know who my primary care pilot is? You know, and I don't, but I know that I can trust, for the most part. I can't necessarily trust my baggage is going to get there, but I know that I'm probably going to get there in time. So it's this notion of thinking differently about systems and how we can trust in systems. I remember when President Obama talked to the AMA on June 15 last year. He said that he was talking about electronic medical records and all this stuff. And he quoted Newt Gingrich, which was funny in its own right. And he goes on to say that, you know, I know that if I send a FedEx package, it's going to go from point A to point B. But I can't tell if my electronic medical records are going to go from point A to point B, or if anything else about my healthcare is going to go from point A to point B. The point is that there are systems that have trust and develop trust, and I think that's where we're going to be, where we have to look. And then the teams will be functioning to build that trust, and there'll be support systems to create that trust. And that's probably how we're going to move forward.
And I think the continuity is clearly, there are lots of C's associated with primary care, and continuity is clearly one of, if not the most important one, and that's what there is promise and sometimes delivery of the continuity through the electronic medical records. But still, the onus is still on the patients, I think, on trying to do this. But let's get some more questions. Yes, right here.
Hi, I'm Lisa Lang from the National Library of Medicine. One of the interesting things that is evolving with the discussion of comparative effectiveness and the center that's been established as a result of the health reform bill is the idea that patients will be left with having to understand risk and have to make decisions about care and care options on the basis of understanding relative risk to them of one alternative versus another. Can you say a little bit about how risk and what we know about conveying risk factors into what you're doing?
So as a matter of fact, there's a book that we just wrote called Making Data Talk, and it's all about how to communicate this information. We fund a lot of people who look at how we can take data and information about risk and put it into a format that people can understand for decision making. And that's, I think, been under-researched a little bit. But we're seeing that happen a lot more now when it comes to using numbers. So I bring out my little iPhone, and I've got a Lance Armstrong application on here that lets me quantify different parts of my life. Nike is pushing stuff like this. So there are ways of doing it. There's a wonderful book by the editor of Wired magazine just recently called The Decision Tree. And in this one, what he says is that the first chapter is all about toxic information. And we thought in the past that if I gave information about risk to patients that was toxic, I was going to kill them with that information. And so we would withhold information, which was more toxic. He said whether we like it or not, people are going onto the web and they're getting our data from NCI And without any kind of hand-holding and interpretation, they're getting inundated with that. So the bottom line to this, I think, is we do need a lot more focus on how to make that risk communication work. We have some ideas now. We need a little bit more. And we need better tools in place to help our providers and our patients to interpret that risk.
Hi, my name is Reed Gedziel. I'm a fourth-year student at the Medical College of Virginia. I guess this question is more for Dr. Gibbons, because he spoke about the e-tools. If patient education is expected if the patients are expected to use the e-tools, do you see in the future that physicians are going to be directing them to certain websites and things like that? Because now when patients get on Google, type it into Google, there's a wealth of information, and they don't really know how to establish credible sites, which might even be overwhelming them more, especially immediately after a diagnosis. So do you foresee physicians actually directing them to sites and helping out with the e-tools and things like that?
Yeah, so let me just, if I might, correct a little bit of what you say. You start off by saying if patients are to use this. Correction, patients are already using this. These are just not tools developed within the context of healthcare. The latest report I've seen says close to 160 million patients are now using or have used electronic resources of all kinds to get information. So this is not an issue that we have to decide whether there's a market for. It's already happening, and that number just goes up every time I look at it. The question, though, about physicians' role, now that's the question we need to think about. And absolutely, I think that is one of the areas, for me, health reform is far more than just health financing reform. It's got to include how do we make it responsive to what patients need, and some will need help in directing them to tools. And it's not just websites, it's all kinds of things. I mean, Doug alluded to it. Microsoft had in the paper a few weeks ago that in the next year they're going to be releasing health applications for their Xbox 360. You laugh, but I heard that the chairman of Sony Nintendo say he was going to do that 10 years ago. And now they have the Wii. Wii Fit, Wii Sports, that may enable people who are wheelchair bound to get upper extremity range of motion exercises which are benefiting them, and it didn't come from the healthcare system. So this is real, this is happening, and we have to think about, yes, how is it going to be integrated within the context of the healthcare system to help patients manage it, those who need our help, or else we, the healthcare system, is going to be left behind in this game. It's
time for two more
worse.
questions. Yep. Here's one and one in the front here.
But Barry was so right when he talks about relationship and
Could you introduce yourself, please?
Making appointments. I'm Deidre Defoe with iHealth Global. My husband summed it up in one word. He said time. He's a family practice physician. I've tried everything. I've done private practice. I would be on call. I come in. I have 30 patients. While I'm seeing patients, I'm called for an emergency C-section. I have to leave all the patients waiting in the waiting room. That's why it's called a waiting room. Then I went into public health because I have an MPH, so I did health department. I walk into the room to see my patient to do her pap smear, and she's dressing to leave. I'm like, where are you going? I've been waiting. I came in 3 hours ago. It's 3 o'clock. I have my kindergartner getting off the bus. In 2 minutes, I need to leave. I tried a federally funded clinic, no access to care. People call me to make an appointment. I'm booked a year and a half in advance. People are leaving messages. They're crying, they're in pelvic pain that they can't see me. One patient said she was going to commit suicide if I couldn't see her for her pelvic pain. Last year at the AMIA meeting in San Francisco, Dr. Smith was the keynote speaker. He stood up and he said, people are going on their cell phones or the internet to make appointments to the restaurants, yet they can't go on the internet and make an appointment to see their doctor. I think patient medical records would be such a great resource to people. And again, you can't have a physician see a patient every 10, 15 minutes. My husband said last night, he came home, he said, I had a 97-year-old patient in AF fibrillation, walks in, I have 10 minutes to see her. He said it took me 10 minutes just to put her to sit up on the table. I mean, we need time. Now physicians are leaving health insurance and they go into practice. They don't take any health insurance. They give patients an hour of their time, but there is a fee. My friend just opened an office. She said, I'm charging $400 an hour. So the key thing here is time. And I really understand what you say. And I told my husband, if I were to ever open an office, I would not have a waiting room. No one should go to see a physician and they're waiting. That's very disrespectful.
Thank you. Last question or comment, and then we'll have final comments from the panel.
Bob Griss with the Institute of Social Medicine and Community Health. We've been talking a lot about the lack of a system. Shoshana mentioned that, and I think we all can understand it. But the experiences that patients have, I'm wondering whether there is any evidence that an independent evaluation of the patient's experience, whether that is being taken into account in the way the healthcare systems evolve. It's one thing for a provider to assess the patient's satisfaction. It's another for an independent evaluation of the patient's experience to see how the delivery system is actually functioning with specific patients. In the air control system, we talk about examining near misses or crashes even. But I'm wondering whether that is being done in the healthcare delivery system. I think that that's a missed opportunity, which is only handled through PR when providers, ask for patient satisfaction levels, because those providers often don't have the capacity to redesign the system. They could, at best, redesign their own service. And I'm just thinking that the patient's experience is not being represented at the community level.
Are there responses to that?
You're talking about at the provider level, not at the system level?
At the system level.
At the system level, some of it is happening. I would agree, not enough. But we have pharmacovigilance now, which is essentially looking at the science of looking at drug administration and drug events at a population level for the express purpose of trying to understand sentinel events or events that may inform us as to where something bad might happen later. So some of that is happening, but I agree more could happen.
I'm Maria Rosa Watson. I'm a research director for the Primary Care Coalition, an organization that serves the uninsured in Montgomery County. And I just wanted to answer to this question because there's a global movement and very little participation from the US right now. It's put by the Institute of Healthcare Improvement out of Boston, and it looks the triple aim that looks at patient experience, population health, and quality by trying to keep the cost controlled and hopefully improve, less cost. So I really, I just wanted to make a point also about a slide from the first presenter in which said that engagement are actions of individuals must take and different than actions of professionals or policies. And I would like to see if we could agree after this conversation that only things that get measured and funded or mandated get done. And so going to all this, the discussion of primary care, if we don't put the resources at the clinics so they can navigate the patients, and there's enough navigation information now, and to support, engaging the patients from the beginning and also in prevention, and I say that as a dentist, that, there's so much knowledge that it's not transferred to the patients, that if we would be able to engage them early on, it could be prevented. And we can say, dental health doesn't kill, although there's a kid here in Prince George County that will have, disagreed with that. So let's please do not forget about prevention, early engagement, and also making sure that the funding is there. So like organizations like ours, we help 14 clinics see about 40,000 patients, but we don't have money for the outreach, the engagement, the navigation, and all that. Thank you.
Last comments from the panel. Shoshana?
No.
Oh, did you have some?
Oh, this is the wrap-up comments.
I think we're out of time, unless you wanted to say something, Judy, real quick.
Good.
Well, it's been wonderful to see the engagement in this topic and to see how much interest there is. I want to tie this a little bit closer to the concept of patient-centered care. That patient-centered care is such a important concept, and, but yet it's kind of like a Rorschach test. Everybody sees it a little bit differently. May I suggest that what patient-centered care is care that really understands what the patient role is and supports it. It's not just about being nice, being respectful. It's really about helping people do what they need to do to participate and to maintain their health. And if we had a truly patient-centered care, we would have much more engagement.
Chris?
So I think something I've really taken from all of this and all the conversations from the audience is that we're at a phase where if we look at chronic care, and we're really confronting chronic care now more than we ever have, we need two things. We need patient engagement, and we need a system that's responsive to that engagement. And I worry about the system. But one thing that I'm excited about is the ability of communities to lobby for a system that's better. And I think we're now at a time where part of patient engagement is this lobbying effort, to not be satisfied unless we know that there's a system that doesn't make us wait for 2 or 3 hours in the waiting room all the time, that where our physicians talk to us by name, and that's what we really ask for. And I think that's one way of really moving this forward.
Shoshana?
Final thought is really about just reminding us that information is not maybe necessary, but it is not sufficient for us to achieve patient engagement, for us to achieve high-quality care, for us to achieve good patient outcomes. That if we are going to achieve patient engagement, it will only be by understanding the diversity of patients and really getting serious about meeting not just their needs for information, but their needs for understanding that this is essential. I mean, we've got a healthcare system right now that isn't even owning up to these engagement behaviors as being things that people need to do. So if the system isn't even owning up, I think it's a far way, and we have to move closer to a way where, as Judy said, it is supporting patients in taking those actions, not just by telling them what to do, but by something much more deeper and much more humane.
Thank you. Final words, Jessie?
Yes. I'm delighted that you all came. I'm so pleased to see both the interest and the enthusiasm and the willingness to kind of grapple with what I think is clearly a critical and largely kind of glossed over element in the success of healthcare in our country. I just have 3 small things to say. First of all, I know that there were lots of questions and hands raised that weren't asked and weren't discussed, and I would invite you to contact us and communicate with us and let us kind of, if we can kind of serve as a clearinghouse for getting your questions answered or engaging in a conversation with you about the questions that you have, that would be great. The second thing is please take a look at the long report, really, and the tools that are available with it. We developed this for you, for those of you who do research on this, those of you who fund, those of you who are advocates. It's great. It can really give you the data that you need to go out and make a case for what it is that your angle on people being engaged in their health care. We're also releasing over the course of the next 2 years on each one of those chapters a white paper called What It Takes, in which we kind of look at what people are doing, what they're not doing, what's required of people in order to do each of those behaviors. And that will also provide further kind of fuel for the fire and support for the larger project of working to ensure that each of us can engage effectively in our health and health care. The final thing is that simultaneously with the release of this report, we're launching a website called the Prepared Patient Forum. The Prepared Patient Forum, some of you probably know that we're a content provider for the media on new evidence related to people making decisions about their health care. And so we just like have this constant flow of news articles that go out, as well as various newsletters and products that kind of capture the essence of that work and make it kind of digestible for the public. All of that stuff is organized on the Prepared Patient Forum under each of those topics, and it's a really nice, navigable, friendly, sweet resource that you can use both to find new data, but also if you have access to if you treat people or you're part of an advocacy group, it's a really nice free tool. We don't accept any corporate sponsorships, so there's no advertising on the site. It's really nice, it's really solid, and I urge you to take a look. It's the preparedpatientforum.org. Finally, thank you again for coming. I hope you found this interesting. I hope you found it stimulating, and I look forward to talking with you further about the ideas we've discussed today.
Thank you very much.